like to tell you about is maybe less about complicated science, but it's more like a social project or program. And from the social point of view, it is quite complicated. And yeah, I'm wondering if you will agree with me. So we all know that medicine is changing. What you see here on the right is the first textbook of modern medicine. It was actually written by Sir William Osler in 1892. Here on the left is a current textbook for internal medicine only. So if we want to gather all kinds and specialties of medicine, it would be, it would cover all the floor here. So we are all changing our knowledge, we are learning, and what we start to know is that there is actually no average patient, and we are hoping that there will be no standard medicine and no standard medical care either. So what is that actually personalizes medicine? It's you, it's each one of us. But the thing is, what actually makes us all unique, and these are our genes. And genes are simple instructions that make our body work. So they encrypt our eye color, the muscle strength, the height. But what is also written there is the illness. So actually, genes tell us what diseases we may be prone to. And when we think about the genetic analysis yesterday, it was a huge problem. So I don't know if you remember the Human Genome Project. So it was the first project in which all human genes were read. So it took 13 years to read the genome of a single person. Now, thanks to the modern methods, which are including actually next generation sequencing, we can read all the disease-associated genes in a week, in a couple of days, and it doesn't cost $60 billion, but just a couple of dollars. And what we know is that really many diseases are encrypted in our genes. So these are most heart diseases, vessel diseases, but what I wanted to show you are examples of two people that were born with a genetic disease. This is Niccolo Paganini. He was a violin virtuoso. And now we actually don't doubt that he was born with an illness. It was a connective tissue disorder that allowed him to play like no one could, because his joints were so flexible. So it was most possibly the Ehlers-Danlos syndrome. And the person here on the left is Angelina Jolie, who was also born with a genetic disease, which is hereditary cancer syndrome. So when we think about numbers and the prevalence of each disease, you have around 27,000 Paganinis in the UK, because this kind of disease affects, like, let's say, every 2,500 people. But I'm wondering if you knew that you have around 1 million Angelinas in the UK. So this is not about her looks. This is about her cancer risk. So there are approximately at least 1 million women in the UK who have the same cancer risk as Angelina was born with. And actually, in the UK, you kind of know it. This is the annual report of the Chief Medical Officer issued in 2016. This is Professor Sally Davis. And what the report said is that all cancer patients should have their DNA tested to save lives. So, but it actually concerned only cancer patients. But we know that since cancer is a genetic disease, then what is written in the genes of cancer patients allows us for better prognostics and for better treatment. And what we decided to do in Poland is run the Hereditary Cancer Screening Programme, and I would like to tell you something about it. And the aim of this program is to stratify the whole population based on the calculated cancer risk and tailor and personalize cancer screening plan according to the patient's own risk. And why, in fact, do I want to tell you about cancer? Maybe some statistics on cancer incidence. So we know that cancer the number of cancer patients is increasing. And in 2030, there will be almost 24 million new cancers worldwide. And as you can see, in the UK, someone is diagnosed with cancer every 2 minutes. But also, when we look at cancer statistics, this is the incidence which is growing, related to the age. As you can see, most cancer cases actually occur in the age like between 60s and 70s. It's really rare that people get cancer when they are younger. But what are the statistics and what do we actually predict? So we predict that 1 in 3 people will suffer from cancer. And what we also start to know is that 1 in 4 cancer patients will develop the disease because she or he was already born with a genetic mutation that increased the cancer risk. And this is quite a recent paper from the Journal of American Medical Association. It was based on really enormous study on, as you can see, almost 20,000 twin pairs. And what they noticed at first is that every third of the twins got cancer, which means it's really 30% of all of us that will get cancer at some time of our life. But in monozygotic twins, if 1 twin already had cancer, this risk was increased to over 45%. And if we look at breast cancer, we can see that every 10th woman developed breast cancer, which means that as we sit here, our cancer risk is 10%. So every 10th of us will unfortunately get breast cancer. But if you look at the prevalence of the disease, when one of the twins already had breast cancer, it grows to 30%, which means that it is a genetic disease. But what is even more striking is prostate cancer. So the risk for prostate cancer is also 10%. But if one of the twins had prostate cancer, the risk of the other one grew to almost 40%, which also means that this disease is absolutely encrypted in the genes. When do we actually think about familial cancers? So we should distinguish between a sporadic cancer, which can just develop in any of us, and the familial cancer, which is dependent on the genes which are inherited within a family. So while sporadic cancer usually has a late onset, so it means that the sporadic cancer usually occurs after the age of 50, 60, then the cancer which is most probably genetic is early. So you usually develop cancer when you're 40, 45. What also happens when the cancer is hereditary, that there is a large family history of the disease, and that there are multiple or bilateral cancers. So multiple cancers means that one person gets several cancers which are not metastatic, or bilateral cancers means that if we have cancer in one of the breasts, then the other one is affected. So when we look at the genetic prognostics and statistics of single cancers, so this is colorectal cancer. So the population risk is 6%, which means that every 16th person will get colon cancer. But if she or he was born with a predisposing mutation, then this risk grows even to 80%. And what is even more important, the same cancer syndromes which cause colorectal cancer also cause other cancers, including the endometrial cancer, ovarian cancer, or stomach cancer, which means that person who has such a genetic syndrome needs completely different surveillance. We cannot concentrate only on the colon cancer, because this person may die from another cancer somewhere in the meantime. And also look what is the average age of getting the disease when it is a hereditary disease. when we look at the epidemiology of breast cancer, it is diagnosed every 29 seconds in the world. And it's starting to be the leading cause of death among women. And again, it's like statistically, the general risk for breast cancer is 13%, which means like every 1 in 10 women will get breast cancer. But when she was born with a mutation like Angelina Jolie, her cancer risk will be increased up to 84%. And it's similar with ovarian cancer. These cancers usually like to go in pairs if they are encrypted in our genes. So the general risk for ovarian cancer is low, it's 2%. But if a woman has a predisposing mutation, then her risk grows up to 40%. Perhaps when you think about breast and ovarian cancer, you think about BRCA1, BRCA2 genes. But these are not only these 2 genes, we already know it. So they are most probably responsible for like 15% of all breast cancer cases. And we are actually getting to know other genes. And there is another recent publication which shows that this PALP2 gene increases breast and ovarian cancer risk to the same extent as BRCA1 and BRCA2 does. And what is also extremely important about breast and ovarian cancer is that when you look at the pedigree like this, you may probably think that this woman should undergo genetic testing and check her cancer risk. But we tend to forget about males in such families, which is a huge mistake. Because the same genes which increase the risk for breast and ovarian cancer increase the breast cancer risk in males from 1 to over 10%, and prostate cancer risk in males up to 40%, which means that they also require completely different screening. What is also very important is that the inborn mutations in cancer-related genes also completely change the prognostics of prostate cancer patients. We treat prostate cancer as relatively indolent cancer, right? It doesn't really kill so many patients, but look what happens when a man has a BRCA2 mutation and prostate cancer. It's like only 40% of all of the patients survive 10 months. So it means that if a prostate cancer patient has a BRCA2 mutation, he requires completely different surveillance. And it's the same with BRCA1, BRCA2, or ATM mutations. Look, when after 10 years, only 40% of all the patients survive. And what we know now is that hereditary cancer is related to changes in 70 genes. And since we have these modern methods of genetic analysis, we can actually analyze those genes and find each one of the persons who is endangered with cancer in a relatively young age. But what we lacked till recent were the exact recommendations, because when it comes to diagnostics and to medicine, you cannot tell the patient that, sorry, you have a mutation, right? You need to give an absolute and strict recommendation how this person should then act, what kind of measures they should undertake to be prevented from cancer. And in 2016, the National Comprehensive Cancer Network, which is like a network of oncology centers in the US, issued recommendations for breast and ovarian cancer diagnostics and genetic assessment, telling us what should be told to a patient if a mutation is found in one of the 14 genes. So what kind of screening should be applied, what kind of risk-reducing procedures should be applied, and so on. And it was the time when we started our, thank you so much, Hereditary Cancer Screening Program. And this program is called badamegeny.pl. It is actually run by a spin-off of the University of Warsaw. It is a genetic testing company, so it is allowed to run genetic testing and give patients the medical results, which then they can use and take to the doctors and just undertake all the, measures they should. So what we do there is we assess cancer risk, always testing the 14 genes related to breast and prostate cancers, which were shown by the NCNN. But we also test 56 other genes related to other hereditary cancer. How is it possible and how does it really work? So it is open to all the patients, but they pay for the testing. Thanks to the grant which was given to us by the Foundation for Polish Science, we managed to run the test for it's actually less than $200. It's $150 for the complete analysis of 70 genes and other factors that I will describe later. So this is available almost to everyone in Poland. This is the website on which each person can register, give us the medical data, give the information to the family tree, but also each of our patients can donate so that the other patient who cannot afford it can get the testing. And what do? We take the family history of each our patient. We want to know if anyone in the family had cancers. We take the personal medical history and we take the genomic data and run the cancer risk assessment analysis. Then we divide our patients into 3 groups. First group is the average risk, which means that there is nothing really worrying in the family and there are no genetic mutations. So each patient is given standard cancer screening recommendation, which is, for example, mammography in the age of 50. The second group of patients are patients with increased risk, which means that they have no mutation, but there were some cancers in the family, so we want them to be, under more strict oncological surveillance. And then we've got the high-risk patients in whom we found mutations, so they get genetic counseling with the medical clinical geneticist, and also get personalized recommendations on how they should then be screened. Okay, so this is more or less how we stratify the patients. I mentioned the genetic analysis, the family history of cancer in close family members, but what we also try to take into account is this. So it's also medical history of the patient, including the drugs that can affect tissue growth, such as steroids, oral contraceptives, and it's all taken all together, and this allows us for a really personalized cancer estimation. But it's not only about algorithms, it's not only about statistics, it's all about giving the patient very strict information on what kind of testing she or he should then perform. So normally when you think about screening for colon cancer, you would do colonoscopy at the age of 50. If you are born with a mutation that increases your cancer risk, it is far too late. So what we propose to our patient, which is of course, based on the worldwide recommendation, is starting the colonoscopy at the age of 25. It's also gastric endoscopy at the age of 25, and urine testing at the age of 25. So it's the only way that we can find cancer in these patients when it's so small that it's fully curable. It's absolutely similar way with breast cancer. Normally, a woman would do her mammography at the age of 50. It's much too late if she was born with a pathogenic mutation. So what we recommend is breast self-examination at the age of 18, and more importantly, it's breast MRI starting at the age of 25. And again, it's the only way that such a woman can be saved from dying for cancer. Also, what is recommended is ovarian cancer screening, which should be started at the age of 30. What is also a very important but also a very difficult subject are the risk reduction procedures, which is the mastectomy, which really lowers cancer risk for over 90%, and of course should be each time discussed with a doctor. It's not that we recommend it, we just recommend discussing this issue with a doctor. But this is also the idea of removing the ovaries, which also decreases cancer risk, and not only ovarian cancer risk, but also breast cancer risk, because it is hormonal dependent. When it comes to prostate cancer, if we find a man who is endangered with prostate cancer, so the recommendations are as follows. It's not a prostate-specific antigen to be tested at the age of 50, but it's actually prostate MRI, which should be done at the age of 40, and then this PSH should be screened also starting from the age of 40. And though it is thought and meant not to be the best marker for prostate cancer, actually for the mutation carriers, it seems to be quite sensitive. And what we also do is that Polish healthcare system is not really perfect. So many of those people would never get public surveillance. So what we try to do is also pay for all this testing in the first year. So if there is a woman that needs an MRI, we provide it to her because we just don't want to let her alone. What are the statistics of the program till now? We've got over 45,000 registered patients. We've tested almost 19,000, including 6.6 patients who already suffered from cancer. And what we found, and it was quite shocking, is that in this general population, there were over 5% mutation carriers, and they had no idea about it. You know, some of them never even had cancer in the family. So without genetic testing, they just wouldn't know, and most probably they would develop cancer early, and they would not be cured. What we also found, screening the patient who already suffered from cancer, in a group of breast cancer patients, I know it's not a very big group yet, we found 30% of patients with a mutation. So this shows that in breast cancer, every third patient gets the disease because she was born with a mutation. And most probably, you know, some of these cancers maybe could have been prevented, but for sure they could have been found much earlier if a woman had genetic testing earlier. But what is even more important is ovarian cancer. We found a mutation in over 50% of all the ovarian cancer patients, which means that this cancer really shows mostly in women who were born with a pathogenic mutation. And in this case, it is fully preventable. And these are the statistics from screening the healthy subjects. I don't have the statistics for all the 18,000 yet, but this is what we got from over 5,000 healthy subjects who underwent the testing. And as you can see, we found the mutations in over 5% of them. We found known risk variants, the mutations which are included in databases, but we also found some novel risk variants. And what is important, this is usually BRCA1 gene, but also CHEK2, which is actually thought to be one of the culpable genes in Polish population. but also look at the quite a new gene, which is NBN, which wasn't so much connected to breast cancer as BRCA1 or BRCA2. And also, it's CDH1, which was recent. I mean, it's known to cause gastric cancer, and its associations with breast cancer have been found quite recently, but it apparently is associated with breast cancer as well. So, what happens if you run such a genetic test and find out that you have a genetic predisposition to cancer? First of all, you should undergo completely different diagnostic procedures. So they should be started much earlier and should be more strict, and you should undergo all the testing much more often than you would normally do. And then the patients who are endangered with cancer or get cancer due to genetic inborn predisposition, they should be treated in a completely different way. But third thing, and also very important, is the influence on the family. Because if I was born with a mutation, then my sister may have it too. And the question is, does she want to know it? And can I not tell her if I had this testing and I know that my risk is high? Or maybe who should tell her? Because it's also a very deep bioethical concern. Should these be doctors that inform the whole families, or should we just leave it to the patient? So, as I've mentioned at the beginning, it is actually a big social issue. So this program is undergoing evaluation all the time. The first thing is actually this problem that for many cancer, there is actually insufficient evidence that using the genetic tests really changes the surveillance of the patient, and that it really influences his life in a positive manner. Because it's a completely different thing when a patient develops cancer and then he gets genetic testing, and we know why the cancer occurred, and then we can treat the patient in a different way. But testing someone who didn't get cancer yet and just finds out that is endangered with this disease is a completely different thing. So this is actually this first thing that we are now also learning from our patients. So first thing is how to better inform the patients about the benefits and harms of genetic screening for cancers. Because, yes, we already know that there are 5% of the Polish population. Okay, I mean, it may change, of course, right? 5,000 is not 36 million. But for sure, statistically, there are at least 2% of people with the high-risk mutations for cancer. So, does the whole population screening, is the whole population screening really worth it? So is finding those 2% and saving them worth testing the whole population and actually leaving people with all this feeling that, did I really want to know? And what can I do with this knowledge? And then how to actually make and assess the overall benefits versus harm that each patient may have. And of course, the most important thing is how to actually implement the decision-making programs. So it is all about education. I don't know what it's like in the UK, but people in Poland don't know much about genetics, don't know much about hereditary diseases. And so it's also making us understand our health and maybe our future better, but it's not an easy task. And before we actually started this program, we had such a survey, a telephone survey, in which we asked people whether they would be interested in genetic testing for inherited cancer, and most people answered yes. And then when we asked our patients who already underwent this testing and were found positive for the mutation. And when we asked them, would you repeat the testing? All of them said yes, because I have a feeling that it saved my life, and now I know what to do. Most of these patients already had some cancer cases in the families, so they already felt endangered, but they had no idea what they should do. They had no idea if they should run the MRI of the breasts when they are 25. They didn't know when to do colonoscopy. They just had no idea what to do to help themselves. So maybe strict and right and clear recommendations will just help people take care of themselves. And yeah, so that's it. Thank you very much for your attention.